Okay. Good morning, Chair. I can confirm that we are now live.
Thank you. Thanks very much, Tom, and welcome to members of the public who may be observing us today. Warm welcome to members of the board and participants for this meeting. This is the second meeting of two boards in common of NHS Coventry and Warwickshire ICB and NHS Herefordshire and Worcestershire ICB Integrated Care Board meeting in common. So a few welcomes and particular welcomes to colleagues. I know Jessica's with us. Welcome, Jessica. You're part of the participating in the patient story today and supporting CAD. So warm welcome to you. We are expecting some colleagues from Health Watch Coventry and Health Watch Warwickshire. I'm not sure whether they've arrived, but welcome or note that they will be hoping to join us, I think, today. We do have apologies from Simon Adams, but Don Beckett is with us again today. Welcome, Don. And of course, I'm sure I've seen Christine earlier as well. So welcome to everybody. We do have apologies from Biraj Palmer. And I also want to note really importantly that this is the last formal board meeting for Dr. Suki Desi, who has been the primary care representative on this board for many years, I think, Suki, certainly for Coventry and Warwickshire. So we're delighted that Suki will be moving on to join one of our provider partners as a non-exec. So congratulations, Suki, from members of the board, and thank you for your contribution over the years. And I'm also wanted to mark that this is Chris Hurst's last board. Again, Chris has, I think, actually worked in many guises across the NHS, and he is stepping down from this role to focus on other things. So thank you, Chris, for your contribution as well. And last but not least, I think this is Russell's last board as well. Russell Hardy, chair of the foundation group. Russell has been a great supporter of this board and of course the two systems through his role. So Russell, we want to thank you very much. I'm sure we will encounter you in other guises over, well, I hope we will anyway, but thank you for your support and thank you for your contribution over the many years that this ICB has now been going. So that's all I want to say in terms of welcome and introduction. Actually, I should also mention, I think Simon, our chief exec, has got a colleague shadowing him, Dr. Abdul Salam, who is a trainee GP who's shadowing Simon, I believe. So he may well be observing the meeting as well. And of course, as I said earlier, welcome to members of the public who also may be observing us today. So I think that covers all my introductions. We are quorate, so we are good to continue. And just a reminder that obviously we have everyone's declarations of interest, but if there are any declarations for specific items that either come to mind as we're going through the meeting, then please raise your hand. And we note that there is on the governance log one action outstanding, but that's not due until July. Is there anything else from the governance log, Hannah, that you would like to comment on?
The only thing I would pick out, Krishni, we have not yet allocated spotlights for the next business year, but we have identified for May, we will be spotlighting children and young people. So just for the board to be aware. So more details to follow. Thank you.
Thank you, Hannah. And that's in keeping with the discussion we had at the last board meeting where we all highlighted the importance of the children and young people's agenda and felt it was a good opportunity to bring that to the fore. So we'll cover that as our spotlight theme in May. So talking about the last meeting, we have our meeting minutes from the 21st of January. Our colleagues content that they're an accurate representation of the minutes. I'm happy to approve it. Any questions or comments on accuracy? If not, I'll take that as approved. Thank you very much. And welcome, Chris. I can see you on screen. Welcome, Chris Baines, and welcome to Stuart. There's such a sea of faces. I can't see Stuart on my screen, but I believe he's here from Coventry and Warwickshire Health Watch, respectively. So thank you for joining us. Okay, well, without any further ado, then we'll move on to the patient and public voice section of our agenda. Now, we do have a number of questions, and we've got different people going to actually do those questions for us. Hannah, would you mind reading out the question for me, because I've lost the sheet on which I've got the first question.
That's absolutely fine. The first question is mine, Krishna. So I'll go straight into the question and answer, and after that,
yes,
I'll
please.
be handing over to Mark Dutton.
Yeah.
So the first question is from a member of the public, and the question is, how do you complain? How long should it take to respond? And if it takes longer, why? What evidence is there to see if a recommendation is carried out? So complaints to both ICBs can be made by post, email, or via telephone. The contact details are available on each ICB's websites. There are a number of factors that may impact on how long it may take for the ICB to respond. And this includes the complexity and severity of the concerns which are being raised, the availability of information required to investigate the matter, and whether multiple organisations are involved and need to be liaised with for the complaint to be properly responded to. So where a complaint cannot be resolved quickly, we will include informing the complainant of the intended timeframe in our initial response. So unless there are some exceptional circumstances, this should be within 6 months of receiving the complaint at the very latest. Often it is much quicker than that. If this is further delayed for any reason, the complainant will be made aware and will be provided with a new time frame. And where recommendations or actions are identified as a result of a complaint investigation, these will be shared with the complainant, and we will seek to provide them with timely updates. The process of handling complaints is currently being reviewed to see what improvements can be made through the work which is underway to align Herefordshire and Worcestershire ICB and Coventry and Warwickshire ICB's approaches.
Thank you, Hannah. That's really helpful. It's a really good question from a member of the public, and thank you for asking that. I think it's really important to note that the communication, if obviously there are delays in responding and there are reasons why responses will take longer. So the second question relates to CHC continuing healthcare funding. I'll read it out just for everybody to be aware, and for the member of the public who raised it to note that their question has been raised in public. And I'll be bringing Mark Dutton, our Chief Finance Officer, in to answer it. So the second question is, I have a daughter who receives CHC funding for her residential placement. I understand from her provider that no uplift in the funding is available this year, as the CHC has not been allocated this from the centre. Given the increases in the cost of living, national insurance and the national living wage, how are providers supposed to maintain the level of support required for people such as my daughter with complex health needs? Mark.
Thank you, Chair. So firstly, thank you for the question from the member of the public. So we believe this specifically relates to the Herefordshire Worcestershire ICB, where a slightly different approach was taken around continuing healthcare uplifts. So for 25-26, all NHS uplift rates are based on an annual assessment of the sector-wide cost pressures alongside the level of funding required to provide safe and effective continuing healthcare commissioned care. From the work that we've carried out across Herefordshire and Worcestershire and benchmarking against other neighbouring ICB areas, we believe we actually pay higher weekly rates because we spot purchase as opposed to going through framework agreements. As a result, therefore, for 25-26, we put in a zero uplift initially to all continuing healthcare funded packages. However, In order to ensure specific clinical circumstances were considered, all our providers then had the opportunity to apply for an additional 2.5% funding uplift via an evidence-based process, which looked at all costs, specific patient need, and the wider market context. So we did allow providers to bid potentially for an additional 2.5% based on evidence and based on a patient need. So that was the position we took for 25-26.
Okay, thank you, Mark. And thank you again to the member of the public who raised that question. And the final question we have is, why are children in Worcestershire not consistently able to access blood tests in primary care? The alternative is Worcester Acute Hospitals NHS Trust, but parents should not have to travel long distances to have bloods done, taking time out from their jobs and their kids' school life to get a simple blood test. So I'd like to invite our Chief Medical Officer, Dr. Will Taylor, to respond, please. Will?
Well, thank you for the question. Actually, it's quite a timely question. So GP practices only take a small number of children's bloods every year in comparison to adults, where many hundreds of thousands are done, especially in younger children. It's a skill set that not all GP practices will have in-house. And it's also not core to the standard NHS GMS contract the GPs work under. So it's an additional role for the practice. Currently, Worcestershire Acute Hospitals do some tests where it's not available at practices. We are aware this is not an optimal arrangement and is inconsistent for children and young people. However, there is a live piece of work looking at a more comprehensive commissioning arrangement for this at the moment, and it is a priority for us. So we will be bringing something back.
Thank you, Will. That's good to hear, because I think we'd all understand why members of the public might want access to that sort of service closer to their homes. So it's good to hear that there's some work ongoing on that count. So thank you to people who've raised those questions, and we'll continue to invite people to raise those questions for future board meetings, which we will try and address. So we move on now to our patient story. The spotlight theme this meeting is maternity and neonatal. So naturally, that's the theme of the story. And I'd like to invite our Chief Nursing Officer, Kath Cobain, to introduce it for us. Thank you, Kath.
Thank you, Chair, and good morning, everyone. As usual, we are beginning this board by grounding ourselves in what matters most, the voice and lived experience of the people who use our services, and we are here to support. Today's is a story from Jess, who is our strategic lead for Maternity and Neonatal Voices Partnership in Coventry and Warwickshire. This is Jess's personal story, and I would like to thank her for taking the time to come and share this with us today. The Maternity and Neonatal Voices partnerships were developed from the 2016 Better Births Review, and they form an absolutely integral part of our current 3-year delivery plan. Jess's work and that of the Maternity and Neonatal Voices partnership helps us to shape services and truly embed co-design, planning and improvement from lived experience into the work that we do, which has led to a really significant impact in both ICBs. National reviews continue to remind us of the need to listen with humility, to respond compassionately, and to make sure that feedback, even when it is difficult, directly shapes how we design and deliver care. We cannot shy away from hard stories because they are often the ones that teach us the most. With this in mind, I wanted to make you aware that this patient story includes matters relating to complications in pregnancy and baby loss, which some people could find distressing. We know that around half of adults in the UK say that they or someone close to them have experienced or at least one form of baby loss or pregnancy loss. It is an emotional and sensitive topic, and your well-being comes first. Please feel free to turn your camera off, step away for a moment, or take whatever space you may need. And if this brings up anything for you, please do reach out to me directly afterwards if you'd like, or to Tommy's, a charity that we've worked with previously and a really valuable source of support. And these resources will be put on the website. It is my privilege to welcome Jess, who has generously agreed to share her lived experience with us today. I want to thank her not only for her openness, but for her service and leadership with the Maternity and Neonatal Voices Partnership. Her commitment to strengthening the voice of service users and ensuring that voice influences commissioning, service improvement and decision making is deeply appreciated across our system. So over to you, Jess, and thank you again.
Thank you very much for that introduction, Kath. So I'll start at the beginning of our parenting journey. My husband and I were married in 2012, and we delayed our honeymoon to coincide with my now brother-in-law's wedding on the East Coast of America in 2013. And we were there for 3 weeks, travelled down the East Coast, and on our return we were sitting in JFK Airport, and I started feeling quite unwell. Didn't really think much of it. We were very young and we'd partied hard, so I just thought it was the effects of what have we are living for the last 3 weeks. However, I got home and they're still feeling very unwell, and I went to the doctors, and she was just going through all of my kind of just normal stats, and she asked me about my periods and had a look, and there was quite a significant gap. So she said, well, I'm just going to do a pregnancy test, and it came back positive. And I was quite surprised. We talked about having children, was really excited, but we'd stopped using contraception, and that was as much as we had talked about. Very sadly, though, the next day I started bleeding and I was having a very early miscarriage. So our very first experience of parenting ended in miscarriage. And it felt like a really long time to wait for our next baby, but I became pregnant in 2014, had a very uneventful pregnancy, and she is 11 now, and she is actually sitting her mock SATs this week. She was exactly what we needed to come at that time. I'd lost my father-in-law and my paternal grandmother during that pregnancy, and my mum had been diagnosed with breast cancer and had undergone surgery. So when she arrived in 2014, she was a welcome, just a beautiful gift that we needed. And then we travelled, we went to New Zealand, took her everywhere, had a wonderful time, enjoyed being a family, and decided then again in 2016 that we'd like to grow our family. And thinking about how long it had taken us to get pregnant previously, I studied myself for a long journey. However, 2 weeks later, I was pregnant. And yeah, very early, everything was going well. I went for my 12-week scan, and the sonographer said that she wasn't sure that she could see what she wanted to see, but maybe our dates weren't quite right, and to come back. So we went back in a couple of weeks, and yeah. So I understand now when NHS give you a cup of tea, it's not good news. And they took us into a room and said that they hadn't seen the features that I'd like to see a baby at that point. So they referred us to fetal medicine, and that took quite a long time. So we were waiting in limbo for a week, and then we met our obstetrician, who was fantastic, and we developed a wonderful relationship. But she diagnosed Amelia with 2 neural tube defects. So she was diagnosed with anencephaly and spina bifida. And so we knew we weren't going to have her forever, but we continued with the pregnancy, and she lived, and she was born on the 17th of January 2017 at UHCW. We were surrounded just by the best care, the best, I can't fault it. And, out of my 4 pregnancies, it was the worst outcome, but we had the best experience. And I think that's really important to know, through my journey, and I will come back to that in a little while. But we took time to heal afterwards, and we did a little bit more traveling with Hannah, and after I got pregnant again towards the end of the year, and again I had another miscarriage, and then early in 2019 got pregnant again and had another miscarriage. But so by the time I was pregnant with my eldest son, I was very, very anxious. And my wonderful bereavement midwife at UH was still in contact with. I said, said, Sam, I don't know where to go. I don't know what to do. And she said she'd been thinking of setting up kind of like a rainbow group. So we together we set up the Hope group for families who'd had any kind of loss previously, and that was going wonderfully. And then people started having babies, so we had the parenting after loss group, and it grew really, really well. And I was working with the chaplains and with the bereavement midwives at UH, and then COVID hit and it all fell apart. And it was really difficult to get restarted, but I had hopes after Amelia died that our pain wouldn't be in vain. So we set up a charity called Hannah's House, and it's named after my living daughter, because she was 2 when Amelia died, and it was really hard for us to help our 2-year-old. There was a lot of help for us as adults, as parents, but not to help our child. And so we got charitable status in 2021, and we were going for 5 years. But we had another little surprise that came after I was 40 in 2021, and actually a few weeks after we got our charitable status, and it was still kind of those strange lockdown circumstances. So I'd had a cocktail party at home and it was wonderful, and I felt really unwell. My husband said, that's because you're 40 now. And I'd been out with a friend who smokes, and she lit a cigarette, and I thought I was actually going to be sick. I was driving home and I thought it was very strange. And I thought I'd had this feeling before, and I stopped and got a pregnancy test, and I was 40 and 3 weeks, and I found out that I was having a baby. And so everything was going well. 12-week scan, he was fine. We initially were under fetal medicine again, and our obstetrician looked after us fantastically. But at my 20-week scan, they noticed that he was very small. I started having restricted growth. My placenta was failing. I was in and out of fetal well-being, fetal medicine every week, until it got to a point about 28 weeks where on a Doppler scan they noticed that through the umbilical cord he wasn't getting what he needed. So they kept me in on bed rest. And during that time, I contracted COVID. So I was in a side room. I'm so thankful I was asymptomatic, because I know that whilst I was in the antenatal unit, there were a lot of really poorly mums, and I felt really like an imposter because I was just sat there drinking tea. I was going for scans every day and having monitoring, but he was very small, and so our obstetrician decided that I was going to come in at 31 weeks plus 2, and the dates changed ever so slightly, but I was admitted at just over 31 weeks, and I had a magnesium transfusion just to protect his brain function, because he was small and we knew he was going to be delivered. But the next day he was really starting to struggle. My obstetrician came off clinic, and I still was a little bit unsure of how things were going to happen, what was going to happen. But she came in and she said, we're going to go and to deliver him by C-section. I said, okay, when? She said, now. And from that moment, it was 28 minutes by he was born. He was 990 grams. He fitted in the palm of my hand. And I was really thankful to hear that he came out with a mighty roar. He was taken off to the intensive care unit, and I was just so thankful to the neonatal staff, because they managed to get my hospital bed into the intensive care. So I was eating my tea and toast, and I got to see my baby. But actually that started a really difficult journey of being in neonates and me being up in the ward. So UH, the neonatal and the postnatal care on different floors. I had a lot of comments from midwives about how I should be walking already, 12 hours after having a C-section. I had a lot of unkindness. The neonatal staff on the other side were absolutely fantastic. And one of the neonatal staff noticed that I was really unwell about 36 hours after I'd had Elijah. She sent me back up to the ward, and I had a massive hemorrhage and was slept for 12 hours. But it was actually the experience with Elijah. Although we had a great outcome, he's about to start school in September. He's wonderful, and those who I've met through the MMVP will have seen him grow up, because he was about 16 months when I took on the strategic lead. The care was so varied, and a lot of it was really unnecessary. He came home 2 weeks before his due date at £5. We thought he was huge, but the transition to health visiting was very difficult. We had real contradicting care advice to what was given to us through neonatal staff. And it was that at that time I became aware of the MMVP, and they were advertising for a role, but I just thought it was too much. But a few months later, it was the chair then became available, and I applied for it and I got it. And the MMVPs have such a wonderful job to do. You know, we work with the healthcare professionals, we work with trusts, we work with the NEDs, the family nurse practitioners. We're not just here to hear complaints about the trusts. We have wonderful opportunities to do co-production, but it was really my experience through Elijah's birth and our subsequent care that drove me to want to make things better. I just think through the role, I inherited a team that were very demoralised. I said I was going to stay for 2 years. It's just coming up for 3 years. And we have built some great governance. We've built really great relationships. We're trusted by the families who trust us with their stories. And we've had the opportunities to build that service user voice into the services that we commission. But I just think as an ICB are clustering together, we've got a great opportunity in commissioning our services. You know, that strategic commissioning journey is a great opportunity to think about to make sure that women and the families are at the forefront of all of our perinatal, our maternity and neonatal services. So I am hoping that I am leaving a legacy. I told Kath earlier this year that I will be standing down at the end of this financial year. I've had many tears with my team about leaving, but it's a little bit like Nanny McPhee. I think when they don't need you, but you're there, but when they want you to stay, it's time to go. So, you know, in terms of my lived experience, Elijah will be 5. He's going to school in September, and it is the right time for me to leave. And I feel like with any other corporate job that I've held, I would have just left. But you know, the people that work in these services are so passionate about bringing babies into the world safely, and also about making sure that we have experiences in pregnancies and births that aren't traumatic, that leave mums without needing care. But I just, throughout everything, I think communication is the basis of all that we do. As healthcare professionals, we can say a lot of things, but it's really important that the people that we're working with know what we mean, not just what we say. So I would just like to leave that with you. So thank you very much for listening to my story. I appreciate your time.
Jess, thank you so much. Thank you once again, not only for today, but for the impact that you've had in this role. And I'm absolutely gutted that you're moving on. I know I met you some time ago when we did interviews for us in Herefordshire, Worcestershire. But I know that you are you move on and you continue to work with your work regionally. We're really grateful of your experience and the leadership that you've shown, and that will still go on to shape maternity and neonatal voices across that wider system as well in the Midlands as well. So thank you ever so much, and back to you, Chair.
Thank you. Yeah, I mean, I just would want to add my thanks, Jess, that, you know, it's incredibly powerful to hear your personal experience and difficult obviously as well, but important for us to, thank you for sharing it, and thank you for giving us the opportunity to learn from it, which I think is the really important point here. Jess, are you comfortable, and please say no if you're not, but are you comfortable to have a look, to open up to questions if there's anything that colleagues want to ask you, not of a personal nature, but more about learning and experiences that might help us? Is that okay? Please say no if it.
Yes,
Yeah,
please.
okay. And Kath, similarly, there might be things that you can help with, or other colleagues. So is there anything that anyone would like to ask Jess or Kath? There might not be, Jess, but Sue Noyes.
Jess, I just wanted to say thank you so much for your story, and thank you for the contribution. As chair of UHCW, it's very moving to hear, but I also know the impact that you have had, both with the other colleagues there, and I really appreciate it. And thank you, and I wish you well. I really do.
Thank you, Sue. Vicky.
Again, thank you very much, Jessica, for your very powerful story, and just the way that you've articulated it all. It's been amazing. I wanted to just ask you, just with your reflections back on your story, that what you think, it's really hard, isn't it, whilst you're in the experience, to be able to pick up where there was a more negative care element within. So you described neonatal, you described your postnatal ward, but is there anything that you can say in reflection that you could have perhaps shared with colleagues at the time, or whether you've been back to colleagues on that postnatal area to be able to share this experience, just so that they're much more aware of the impact that it had on your journey?
Thanks, Vicky. I actually think at the time I didn't really realise that it wasn't great care. You're so just so full of hormones, and being in the nothing prepared me for being in the neonatal unit, and so at the time, no, I didn't. However, through my work, through the MMVP and through Hannah's House, I have definitely fed that back. And in fact, I was at UHCW yesterday. We're doing some anti-racism training with the staff there, with the leadership, and sometimes as healthcare professionals, it is like an instinct to be defensive, and actually, even if there's nothing you can do, listening with empathy is my biggest takeaway. That's what I tell everybody. I present at the Coventry and Warwickshire LMNS board. I know the governance is changing slightly, but that's always what I ask when someone is presenting. Please listen with empathy. Yeah, there's probably circumstances which it occurred. There might be exceptional circumstances, but actually, and I know sometimes it feels a little bit like someone's critiquing your living room, but actually, just listen with empathy. And often it's a hard thing to come and say that this was my experience and it was really traumatic, or it left me feeling unsafe, but actually they might not have another forum to talk about or in it, and just they need to be listened to. Families need to be listened to, and they deserve to be listened to. But Vicky, I can see you're a non-executive member. We have really strong relationships with our NEDs, and they are a real asset to our working relationships with our trust. So, and that's something else that I would say, just if that's your portfolio, please reach out to your MMVP lead. We've got 3 within Coventry and Warwickshire, soon to be 2 within Hereford and Worcester. So please do strengthen your relationships with them.
That's lovely. Thank you for that response, Jessica.
Thank you. Russell.
Just quickly, Jess, that was a very moving and important story for us to hear, and I'm not sure what you're doing next in your career, but wherever you're going, they're very lucky to have you.
Thank you.
On the substance, you said at one point that the opportunity that we have as a clustered ICB, and I just want to emphasise that for a second, that we know there is enormous opportunity, as clearly indicated by the various different maternity investigations that are going on to improve maternity services within the NHS. And I'm sure across all of our providers, we are working very hard to provide the best maternity services we possibly can. But wouldn't it be wonderful in those tragic circumstances that you've referred to, Jess, and I'm sure there are people on this call who have lived through similar situations, if Coventry and Warwickshire and Hereford and Worcester became known for providing the best bereavement services for people who had suffered baby loss. And I think that would be a wonderful legacy for you, Jess, and the work you've been doing in your geography. And I would just encourage, and I know Simon sort of picked up on this in some of the comments, I think we should really think about the way we take forward Jess's work to try and ensure that we become an exemplar within the NHS for bereavement services when baby loss occurs.
Thank you. Thank you, Russell. Kath, do you want to make a final comment? Because I think anyway, we've got obviously a spotlight item on maternity and neonatal, so we'll have an opportunity to talk more about our services and where we're working on improvements. So that's important. But anything, Kath, you want to finish on?
Just again, just really thank Jess, and Jess, I'll be seeing you. Okay, thank you.
Jess, I think you're going on, you're not leaving, I know you're leaving us or leaving this role, but I got the impression you were joining a regional role. Is that right?
So I work in the perinatal team for NHS England Midlands. So I support all of the ICBs across the Midlands and their strategic MMVP leads. So it's not a hard exit. Kath is not rid of me. I shall still be here.
We're very pleased. We are very pleased to hear that. Thank you for everything you've clearly contributed over the several years, 3 years, I think you were saying. And thank you so much for being willing to share your story with us in this public forum. Thank you, Jess. Take care. And thank you, Kath, for helping us through that story as well. As I say, we will be coming back to, I think you and Rachel are going to take us through the spotlight item, item 10, which we'll come on to. So we will move on to the strategic updates and come back round to this theme shortly. And I invite Simon, our Chief Executive Officer. Simon, for highlights from your report, please.
Thank you, Christian. Good morning, everybody. I mean, that was among the most powerful patient stories we've had. And if ever there is reflection on the importance of real life patient experience and the role it can play in our decision making, I think that last 15 minutes really encapsulates that nicely. So we'll do the second part of that when we come on to the report on maternity and neonatal. In terms of my report, again, I hope people have had a chance to read it. There's lots in there. This is designed to provide wider context and things of relevance that are happening right across the cluster. As always, Christian, I'll draw out a couple of things. You've mentioned already the board changes. I'd like to add my thanks to Suki and to Chris for their contribution, particularly during this last 12 months of transition. Moving through the report, our internal change processes within the ICBs continue. We're close to being able to finish the consultation on the next round of organisational change. I mean, the headline for the board is we're pretty much in the place now where we have met our cost savings reductions, or we will have met our cost saving reductions. There are 166 people who are leaving the two ICBs through voluntary redundancy over these weeks. And the next few weeks looking forward, and we've got another 20 people on top of that who left under a mutually agreed resignation scheme. So lots of internal change, but we are right on track to where we wanted to be and where we needed to be. So hopefully we can now start to look forward, actually, and we can start to look with a bit more optimism about some of the externally focused work that we will be doing. We've had to be quite internally focused during times over the last 12 months. We can be more externally focused now on the strategy and the commissioning planning moving forwards. Quick point on page 3 of the report. So we have now agreed contracts with all of the trusts in the two ICBs, which is great news, and I pay credit really to everybody involved in that. There's an enormous amount of work goes into the business intelligence, data analysis and financial planning and structuring of those contracts. So to have got to this point in the middle of March and have completed those, the teams in the trusts and in the ICB actually deserve great credit. So we're looking forward to finalising those plans with the trusts, and then we can get on and deliver, can't we? Then the 1st of April is only 13 days away. We can get on and deliver for patients as well. But some good news around contracts. The report identifies the emerging cluster strategy, and we've got the 5-year strategic commissioning plan as the next item on the agenda. Board members will note we discussed that at both of our development sessions in January and in February. But just to reiterate, really, that this is going to be a fairly iterative process. We're going to keep developing this over the coming months. This isn't a type of strategy that we will draw a line in the sand and then just get on with it. We need to keep evolving and developing our thinking, and that is collective thinking that we've done really over the course of those 2 sessions. But there'll be further work to come through that process as well. If I could just draw board members' attention on page 7 of the report. Quite an important policy development 12 months ago that Coventry and Warwickshire ICB suspended adult ADHD referrals in order to try and focus local capacity on being able to do children's assessments for ADHD. Strategic Commissioning Committee have looked at this in some detail, and just to draw people's attention to that, pause is being removed next month, and we will start to accept adult ADHD referrals. There's a lot of work still to do on balancing capacity and demand in this area. I think certainly that policy change has helped, but we do need to get on offering an all-age service for this now moving forwards, and that's really, really important. It would be remiss of me not to point out at the bottom of page 7, Paul Walker's on the call. Congratulations to Herefordshire Council, who received a good Children's Services Ofsted inspection. Quite a journey of improvement for Children's Services in Herefordshire, and Paul and the team deserve great credit actually for achieving that result. The ICB has been a big part of that improvement journey, and will be committed to continuing that improvement process, both in Herefordshire but actually in the other 3 council areas as well, where I know this will be an ongoing focus really. And then finally, Krishni, I'm asking for the board's approval for the delegation collaboration agreement, which is attached in Appendix B. So NHS England, as part of the process to delegate more oversight and management of specialised commissioning services to ICBs, they're asking the board to agree the delegation collaboration agreement. Again, that's something we've reviewed in detail, and we think that's appropriate, but we do need board approval of that. So very happy to take questions on any of those things, Krishni, or anything else that's in the report.
Thank you, Simon. So happy to open that out. We'll come back round. Obviously, there might be some, if there are any questions about the items that require approval, we'll take those as well, and we'll confirm approval at the end of this item. So I'll just open it up. Would anyone like to ask any questions or make any comments in relation to Simon's report? Very unusual if there aren't any. That would
unusual,
be a first.
Excellent news.
Well, I have to make up for it, Simon, because I've got a long list. So I'll start, shall I? But if anyone else wants to come in, please feel free. I won't necessarily ask them all, but I did have a list. Simon, just on the section where there were items listed as areas of non-compliance that we'd submitted in terms of the 3-year activity and performance plan, I really just wanted to understand whether there was anything significant about where we say that NHSE have accepted the trajectory, and then there are areas where the acceptance of the trajectory is not indicated. I just wondered whether we can assume that NHSE have accepted the trajectory we've proposed on all of it, or are there outstanding issues on this that we need to resolve? So that was the first question I had.
Yeah, and just very simply, I believe we have resolved all of those outstanding issues. As ever, there is quite a rigid national framework for most of these national indicators. We often then have to discuss some local context that means the trajectory might have to be a little bit different locally. My understanding is, and we've still got another week or 2 to go to get these plans finalised, but as of today, NHS England are accepting of all of those local mitigations we've offered. So I wouldn't highlight to the board any areas of concern with that. The non-compliance is merely a technical point around at a moment in time, but the trusts have done a fantastic job actually across the board in these plans, and I think we'll enter the new financial year actually in better shape in both ICBs than I think we've been for a number of years, both in terms of the quality of the contracting work we've been able to do this year, which I think is definitely has definitely moved forward, but actually our understanding of performance challenges and improvement plans, I think they're in a pretty good place. We've got to deliver them, which of course is a whole different matter altogether, but certainly the plans are robust and strong from my perspective.
Thank you, Simon. That's helpful to hear, because I think there's a submission required today to finally back to NHSE. A couple of other areas. One was just to really, I think, really important given the conversation we had about neighbourhood health at our last meeting in January, which I think was a really helpful stocktake. Reflected in the minutes of that meeting for anyone who wasn't present. It really important, I think, that we're making investments or putting aside some funds for investments in neighbourhood health. I really just wanted to reinforce the importance, I think, for us of there's a little bit of feedback, so I'd be grateful if people could turn off their microphones if it's on. But investments in neighbourhood health outcome, it's just really whether we're clear about outcome measures and benefits, because I think it's really important in the context of strategic commissioning that we, and it's mentioned in the commissioning, strategic commissioning plan that we've also got on the agenda today, the importance of having measures that really demonstrate that these funds are being put to good use. So I just wanted to make a comment on that. Maybe I'll just make another comment as well, Simon, so it's not just a conversation between you and I, and you can come back on that and other points. The other thing, just in terms of local authority, obviously the unitary authorities and the reconfigurations that are being proposed or being considered. There's emphasis on hospital services, but I wondered what the impact, if we've got county-wide community services and mental health services, I'm assuming in any consultation response we should be highlighting the impact on those as well, because it's not just hospital services that would be impacted by changes in local authority configurations. So I wanted to highlight that, and then really just comment on, to congratulate all partners, but particularly obviously colleagues at Herefordshire Council for the good, achieving a good rating. I know that's really important, and Paul may want to come in on that. So that's all I wanted to say. So just Simon, on the comments regarding neighbourhood health and the consultation response on the local government configuration, if we could just make sure we're picking up the impact on all health services where they are delivered county-wide, assuming that there is an impact. I'm taking that as for granted, recognising obviously that these are decisions for our colleagues in for government.
Yeah, and I'm very happy to pick that up. I mean, obviously this is a huge development issue within the local government community. There will be significant implications for us in a number of ways, actually, but that's a really good point. We'll make sure we can draw that out. We want to respond to the consultation because we want to be constructive and we want to be a partner, but that's a good point, Christine, that we can draw out as well. I suspect from a board perspective we're going to be having some further conversations over the coming months as the local government devolution plans start to emerge, both in terms of unitary authorities and then probably within the next 12 months around strategic mayoral authority membership. We're going to be talking about that a lot more, so I think it's well worth flagging that for people's attention. Just to your point around the neighbourhood health funds, I mean, we're still working on those outcomes because that is important, as you say, from a strategic commissioning perspective. We are developing an MOU with each of the lead providers as to how we'd expect that additional funding to be managed. I mean, fundamentally, this is the start of a process where we need to mitigate growth in urgent care demand. That funding is fundamentally going to be provided to make urgent care demand growth lower than it otherwise would have been. So that really is the trick we're asking for the lead providers to pull off with local partners, is if we've had 3%, 4% growth this year, well, we need to try and think about, well, what could we do that would make that growth in activity less next year? Ideally, we'll eventually get to a point where we're having reductions in urgent care activity because the left shift is happening and the neighbourhood services are working so well. But I accept that there's a stepped and incremental approach to get to that point. But yeah, we'll keep the board updated as to how that the finalisation of the outcomes, the development of the MOU, and actually through the year about how each of the lead providers are progressing that in the 4 areas and how they're getting on, what the outcomes are. I think that's something strategically that the board will need to be aware of.
Great, thank you, Simon. I can see a couple of colleagues would like to come in. So firstly, Paul Walker, please.
Yeah, and it would be remiss of me not to respond to children's services. I think you know me well enough by now. Whenever I get the opportunity, I always kind of celebrate the achievement across children's services and a kind of system-wide approach to taking forward children's services from our inadequate rating through to children's services in Herefordshire being good, with outstanding leadership and management. And I think that leap from inadequate across all areas to having outstanding leadership and management is absolutely significant. And I won't say it's kind of unheard of, but it is hugely special in terms of an achievement in children's services, as is the kind of the overall judgment of good and the impact on improving the lives of children and young people across Herefordshire, which is why we all do what we do in many respects. So thank you for all the support from partners to allowing that to happen. We remain in intervention. We have yet to have that confirmed by the Minister. We are expecting a subsequent final report from the Commissioner later in May, and then that will be presented to the Minister in terms of consideration of removal of the intervention, and Herefordshire then continuing on its way with its phase 3 improvement plan and continue its improvement journey. So yeah, much to celebrate. People are quite rightly still smiling. Still lots to do. But no, thank you for the support from everyone in the organisation, and thank you again for raising it.
Thank you, Paul. No, I think it is really important to celebrate these moments, but as you say rightly, continue to build on them, because we all know that continuous improvement is really important. So yeah, absolutely huge well done to everybody who's involved and contributed to those improvements. I think Pete wanted to come in. Pete?
Yeah, thanks, Christine. So in a similar note, and I know Becky won't say it for herself, so I'll say it for her. I also like to just give a shout out to Warwickshire County Council, who achieved a good in adult social care. And you know, that is not just Warwickshire County Council, that's how they work with partners and part of the system. So one of the things that we all need, we need to celebrate these moments, but ensure that as we move through reorganisations and LGR, that we don't make backward steps, that we continue to move forward. So Becky would never say it for herself, but just wanted to put on record the call for Warwickshire, and they're good too. So well played them.
Brilliant, thank you, Pete. I did drop Becky a note, I think, to when I saw the news, and it was very good news, and I think a number of partners were interviewed as part of the process, weren't they, Becky? So it was really positive to see that outcome, and really important, as we've said, to celebrate these. So Pete, thank you for highlighting it, being the good partner and highlighting it for our Warwickshire colleagues. Thank you very much. Okay, well, one final item as part of Simon's report was obviously the approval relating to the establishment of what is being called OPIC, I think, for short. Am I right? Is that the right term?
Yeah.
So it's this. It's a delegated arrangement, isn't it? For joint and collaborative committee on behalf of the Midlands ICB. So it is a little bit different, isn't it, Simon, from what's established currently, because it's moving from an east and west separate arrangements to a joint arrangement. Do you just want to briefly comment on any? I mean, obviously there's a MOU and a terms of reference and a sort of documentation that's been developed. I'm assuming that's been subject to some kind of independent review, or to at least confirm that this is a suitable mechanism, if you like, for all of our organisations to sign up to. And are there any risks that we as a board should be aware of? I think in the scheme of delegation that comes about later, there are some clear items. Hannah actually might want to comment. I think we've assigned to that body, but if you want to comment, Simon, and maybe Hannah could come in as well, that would be useful.
I think Krishna would just say this is a big opportunity for the cluster. I think one of the observations people will have had about specialised services commissioning is it traditionally has focused around the biggest tertiary providers. We've obviously got a big tertiary provider in our cluster who we will be looking to use our new delegated commissioning leadership to explore how we can develop some of those pathways more locally. I think this is a big opportunity to do that. You are right, it was organised across the East Midlands and the West Midlands in two different ways. Bringing it together in one place, I think, is a benefit because it gives us more scale, but also clearly it's going to be located in BSOL Black Country, who are a neighbouring cluster to us. So just to give the board assurance that we'll be looking to use this new influence to try and drive some of the local pathway development that will be really important for our patients. We want better access to specialised services for people that live in Coventry, Warwickshire, Herefordshire, Worcestershire. Having the delegated responsibility will be a great way of unlocking some of that. So that's certainly the aim. Yes, we have built a scheme of delegation that sits alongside this. My only caution is it is of course quite different. It's quite a big change for the staff involved. We're definitely going to have a development programme so that we help the staff that are transferring into this new facility to really understand some of the local context and issues. So, I'm not expecting instant miracles, but I am expecting a 12, 18, 24-month journey of development where we can hopefully start to make a positive impact on some of this.
And I don't know, Hannah, if you wanted to add anything in terms of governance, but I was just going to I think there was some suggestion there'll be a regular report or something that comes to all ICBs, so we as a board are cited on decisions that are being made. So I saw Hannah nod there. So Hannah, do you want to comment?
Yeah, I mean, the only thing I was really going to say, Chair, is that obviously it has been through all the governance due diligence, and all the governance leads across all ICB clusters have been involved in designing it. So, it is absolutely right and proper and in line with our scheme of reservation. Delegation reports will be periodically provided to this board, but also Strategic Commissioning Committee for the cluster will be kind of I suppose it will have oversight of all delegated arrangements in terms of commissioning. So there is kind of a dual oversight, and I'm quite happy that the assurance is in place.
Great, thank you. So on that basis, and on the basis that there weren't any other questions or comments regarding that proposal, can I ask the board to approve the NHSC Delegated Services Collaboration Agreement, which was Appendix B, and the Joint Collaborative Committee Terms of Reference for the Midlands, which was Appendix C, for us to adopt as a way of working? Take that as a yes, thank you. Okay, Sue, did you want to come in? No, you're happy to.
No,
indicating
I was endorsing the decision.
Endorse.
Very much endorsing the decision. Thank you.
Great, thank you, super. Right, lovely. Well, thank you, Simon, for the report. We will then move on to item number 9, which is the 5-year strategic commissioning plan. Rachel, over to you.
Thank you, Krishni, and good morning, everyone. So in order to support this, you will have received, I hope, the full plan and also a short briefing paper. But in order to bring the plan to life and make it easier for people to understand, if you haven't had the full opportunity to read all pages, then I thought we'd just do a few slides which actually describe what's in the plan, which might help with some of the conversation. So all ICBs are required. Can we have the first slide, Sharon, please? So as you'll be aware, all ICBs were required to produce a 5-year commissioning strategy, which will demonstrate how we will work with our partners to deliver the 3 shifts in the 10-year plan and improve health outcomes for our population. We submitted our plan to NHSE on the 12th of February, when we're still actually awaiting feedback, formal feedback, but we've had some positive informal feedback. The plan does come in 4 parts, as shown there, and each of our providers have also developed a delivery plan which responds to the documented commissioning intentions. And we're in the process of actually aligning and looking at how their plans and the commissioning intentions sit side by side. And as Simon described earlier, this is an evolving process, so we don't expect it to just be a plan that sits on the shelf. It'll evolve over time. Next slide, please, Sharon. So the plan includes a bit of a cluster overview with regards to our population, and also describes some of the healthcare services that will be transformed by the commissioning intentions that we've reflected in the plan. Next slide. It also outlines the key activities that we'll be focused on in terms of trying to deliver the 3 shifts in the 10-year plan, and some of the key outcomes, to your point earlier, Krishni, that we'll be looking to try and achieve as we undertake those activities. So trying to get a much better, more clear approach with regards to the changes we expect to see for our population. Next slide. The plan describes our approach to strategic commissioning and becoming a strategic commissioner, with 2 key priorities that we've identified for 26-27 in relation to commissioning for sustainability and integration, and then also commissioning the prevention of ill health and addressing health inequalities. So expect to see more on those 2 particular key priorities. Next slide, Sharon. The plan also describes the foundations of our cluster strategy, which I know the board have really helpfully been involved in helping us actually co-produce. It has evolved since our February Development Centre, as you'll see there, and we are currently engaging on this strategy with our partners, in particular the building blocks and the programmes of work which we'll be focusing on across both ICBs. And certainly we'll be looking to try and describe at some stage in the near future how those programmes will be designed around population need. Next slide. So the plan articulates the 4 drivers of transformation, which are going to help us actually deliver the plan. So a key function around population health management, the work around working with our patients, and having heard Jess's patient story this morning, it's really emphasised the importance of having both people and community involvement and participation in our commissioning approach. Innovation's a big element, as everybody will be aware, in terms of how we actually create the conditions to actually move from the way we deliver services currently into a future model, and also our vision for our workforce, particularly in relation to the work we'll be doing with partners around integration from a neighbourhood health perspective. Next slide, please, Sharon. So in terms of our next steps, As I say, we've commenced engagement with yourselves as board members and other partners, and we'll continue to do that as the plan evolves. We're in the process of completing the management of change, as Simon describes, to provide the capacity that we'll need to deliver the plan. We are starting the work to develop our PHM approach, which will include an integrated needs assessment. And once the National Strategic Commissioning Development Programme is launched in April, we will start to build our core capability and expertise in regards to our new role as a Strategic Commissioner. Mark and the team have already started work on developing a new financial framework that starts to support us be able to move resource from an acute setting into more of a community setting in line with our neighbourhood health commitments. And we'll be working jointly with our partners to better quantify the outcomes and benefits of our commissioning intentions, and how we transform and integrate services and demonstrate success in that area. And then all of this will be pulled into a delivery plan, which we will share towards the end of Q1, early Q2. So, as I say, we've shared the full plan. Again, just wanting to reiterate that will change over time. And that was all I was going to say, Krishni, but happy to take questions.
Thank you very much, Rachel. Really helpful just to talk us through that. Sharon, are you happy to take the slides down, and then we can just take some questions or comments from colleagues? And I think particularly as Rachel has highlighted, there's an opportunity to sort of shape the ongoing direction of this through comments that colleagues may want to make. So there's quite a lot of comments wanting to come in, so maybe I'll take a couple at a time if that's okay. So we'll take Russell and Shaquille first in that order, please. Russell.
Thank you, Krishni. Rachel, thank you for your leadership on this work. I did, for my sins, read all 127 pages, and it's good stuff. I think this is an incredibly important body of work because the whole of the 10-year plan involves a transformation in the way healthcare is delivered, and that needs to be actioned through the ICB in the way it strategically commissions. I worry, though, that the current version isn't quite clear on what I think some of the numbers look like and the consequences of the numbers for the system. So if I can just rattle on for a few seconds, Krishni. The NHS is given a 3% real increase in funding over this Parliament. But if we're going to really strategic commission and increase on prevention, increase on neighbourhood health and delivery at home, at its simplest, and I am oversimplifying, what that means for the acutes in the middle is its real funding increase is going to be about 0 or 1%, because the money is going to go into prevention and into the community and the delivery at home. And the consequences of that for the acutes over the next 3 or 4 years and their plans is very, very significant in a way that I think generally the acutes aren't yet smelling the coffee. And so I think that the sooner we can get clarity out to the system, what this plan actually practically represents in terms of funding is a very small, if anything, real increase into the acutes top line. The consequences of that for the acutes is a real drive forward in terms of productivity, outpatient transformation and procurement to be able to deliver within that very, very tight financial envelope. On the prevention side, the working with primary care colleagues, we must stop the flow of patients into the A&Es in the acutes, which is incredibly expensive and puts them under enormous financial pressure. We need to do that safely, but we need to put the genie back in the bottle, which escaped in COVID, of people often just coming to the acutes A&E. And on the community, more healthcare in the community, in that particular regard, whether it's done through host commissioner route or lead commissioner route in an acute setting, but being really clear about what the outcomes are there and what we'll be doing differently, particularly with social care and domiciliary care providers, to get better value for the taxpayer. So I'm really supportive of the words. I just really want the numbers to come through, because the numbers are going to be so dramatically different from the last 5 or 10 years that for our acute colleagues on the call, the consequences and the need for them to be delivering practical solutions on productivity, outpatient transformation and procurement is very, very real.
Thank you very much, Russell. A really powerful point. I will take another comment from Shaquille and then invite Simon, Rachel, whoever wants to comment on these things as we go through. So Shaquille next, please.
Thank you, Chair, and thank you, Rachel, for this very nice explanation. I just wanted to be brief. I just wanted to ask that in terms of left shift, how confident are we that workforce and estate capacity across primary and community care will support the pace of hospital to community shift described in our strategy?
Thank you, Shaquille. Can I invite either Rachel or Simon, I'm not sure, or Mark for that matter, any executive colleagues who want to come in on those 2 points. So it's the impact of left shift really, but I think Shaquille's perspective was workforce and estates, but actually Russell was also highlighting, the impact on acute funding and being really kind of clear about what that might look like. So Simon, do you want to start? I can see you're off your
It's a really good, valid question. I'd probably bring Mark in actually, because what Russell's describing is we've got the strategic commissioning plan, but actually without a financial plan that sits alongside it and is totally consistent, it's all a bit meaningless, isn't it? So it's how are we going to reflect the changes that we're describing in the medium term financial plans, which is where you will see all of that. And it really then, what we would expect, Shaquille, alongside the 5-year financial plan is a similar time frame of workforce planning, which indicates the shifts that you are describing, that i.e. we will need more community nursing capacity. Those numbers will increase, and maybe some of the staff who are employed in acute hospitals delivering outpatient clinics will potentially be working somewhere else in a different setting. So we will need to piece all of that together. But Mark, do you want to just describe how we'll feature this in the medium-term financial plan?
Yeah, absolutely. Thank you, Simon. So, Russell, you're absolutely right. We've got 3-year allocations now, with 26, 27 being year 1, which does give us an uplift for each of the 3 financial years as part of the comprehensive spending review and the settlement that was agreed with government. What we're seeing though is, particularly in years 2 and 3, the uplift that goes into the acute sector is pretty much flat cash. So there's very little that goes in terms of price growth. The bit we still need to work through is what the activity growth might look like. So the decision we've taken in year 1, which is 26-27, and is the investment in neighbourhood health, to really look at how we start to transform, and as Simon described it, lower what we would have otherwise seen in terms of acute growth through urgent care to how activity can be managed differently. What we will look to do then in years 2 and 3 effectively is build on that to a point where we're putting either limited activity growth into acutes, or looking at how we can take activity out that would have otherwise been through the acute front door. What we'll be building into the plans over the next 2 to 5 years, and we're going to start the conversations at Strategic Finance Committee actually on Friday, is about the allocation we've got now, what resource, based on these planning assumptions, does that give us for out of hospital, left shift, community investment over that time period? And how can we collectively look at how that cost and activity changes, so we can model that through each of the partner plans, so that we can start to see that moving resource out into a different setting. So you're absolutely right, Russell. We've now got to model this and build this alongside all the words that Rachel talks about in terms of the direction and how we want to move. We now need to wrap the finance around it in the same way.
Thank you, Mark. Really helpful. Sue Noyes, please, and then Paul Walker next. So Sue.
Thank you, Krishni, and thank you, Rachel, for this. A couple of points, mine are less on detail and more on the process. Firstly, really pleased to see the focus on benefits realisation. Good to know how we're planning to do that and at what point, because as we move forward in this journey, when are we actually starting that, so we know what we want to achieve. And my question was, had we thought about working with one of our local universities to evaluate some of what we're doing right at the outset, because that feels like it would be helpful. My other point was just to say, on the page, I think it's around page 119, I too have read 127 pages, thank you for that, Rachel. Could we actually explicitly endorse the work of Healthwatch, and just make it clear we value the function of Healthwatch is performing, regardless of what happens to Healthwatch? That's a very important function, and we want to continue to work with them, and whatever, if ever, there is a successor as well. Thank you.
Thank you, Sue. I'm sure we'd all endorse that. So that probably is a relatively straightforward reflection we can make. Was there a comment then about just about benefits realisation and evaluation? Oh, well, actually, let me bring Paul in first, and then we can address that. Paul?
Thanks, Krishni, and thanks, Rachel, for sharing the report and the presentation this morning. And I was pleased to hear that this is kind of an evolving plan and more work to do. As you would expect, as a local authority partner, we have got a strong and vested interest in terms of the impact on our adult social care services. And I think, the significance is not unfounded around operations, around commissioning our public health work, and keen to continue the dialogue and get close to some of the detail and the impact on neighbourhood teams, on financial pressures. I don't see any new money here funding the early help and prevention work that's going to be needed to be done. I think I'm most concerned about potential capacity and capability within an already strained workforce, which I think Russell's alluded to. And just going back to the integrated neighbourhood teams, whilst I'm sure we were all relieved to see the policy framework arrive in our inboxes yesterday, we've got to work through that and understand what's the relationship between that policy framework, our ambitions around integrated neighbourhood teams, and how do we work that across the system. So we are with you in terms of the plans and ambitions. Absolutely, they mirror and align with the things that we had plans for modernisation and improvement across Herefordshire, and I'm sure my fellow chief executives. It'd be good to have that kind of close raised dialogue of how we operationalise that and align plans and resources, both finance and people, to deliver this in the longer term.
Thank you, Paul. So I'm conscious there's quite a lot of people still wanting to come in. So it may be that some of these things Rachel and colleagues will just need to note and think about in terms of including within the next iteration. But anything you wanted to comment on briefly, Rachel, or any other executive colleagues?
I'll just say, Krishni, Sue's point about outcomes is very, very critical, and obviously that's our move to being a strategic commissioner, is being able to actually articulate much clearer than we have previously what are the benefits that we're expecting to see, both in terms of the outcomes for our health of population, but also in terms of the impact it will have to our services. So yeah, and I think Sue's suggestion about using one of the universities is well made. And then to Paul's suggestion, Paul, absolutely, we want to continue that engagement piece to make sure we bring this to life together. So obviously the timescales have forced us to do this relatively quickly. Now is the opportunity to start to actually put the meat on the bones and say, what does this actually mean in real life? And that's where it's critical that we co-produce that piece of work.
Yeah, thank you, Rachel. Okay, Pete and then Suki, please.
That's Christian. So Paul covered some what I said, but I'd just like to, obviously the strategy is good, well written, well articulated, but how we make it relevant for like wildly diverse populations, and that's a challenge, isn't it? It's a challenge. It's been a challenge in Coventry and Warwickshire for years. The health inequalities between inner city Coventry and Shipston and Stour Kenilworth is just wide and well understood. In a bigger cluster, I think that gives both like risk of losing those urban area specifics, those urban area challenges in the context of 3 counties, but also opportunities to learn and share things across the lot. So I just my kind of question is great, strategy is fine. How we make it relevant for all edges of our populations, I think will be a challenge here, and we'll be trying to do that with a much smaller, albeit more strategic ICB, so much less people in the system to do it. So we really do need to think about resources, capacity, priority. But broadly, the acid test is what difference does this make for me as a person on the street, and it's got to talk to all of our population in how we transact this and mobilise it, Rachel. So good work, and just want to make those points really, not for response, just for comment.
Yeah, thank you, Pete. I think, as you say, rightly so, it builds on what Paul said about the kind of making it real, isn't it? That how do we turn it into something that we can operationalise? Suki?
Hi, Rachel. Thank you to you and your team for your work on this. I can imagine it wasn't easy. I've got 2 questions. Given the reliance on sort of partnership working, how are we ensuring that relationships are robust enough to support shared accountability for delivery? And the second question is, does our governance structure give the board sufficient oversight and grip on delivery across what looks like quite a complex partnership system, really?
So this, I don't know whether, partnerships point, I don't know if Rachel wants to pick that up. Certainly, we might want to comment at this point about the collaborative arrangements and how we kind of plan to take those forward, Rachel.
Yeah, thank you, Krishni. So it's a really good question, Suki, and it is going to be a real test in terms of the maturity of our accountability arrangements across the system. So if we consider what Mark has described and Simon has described earlier around the neighbourhood health monies, that is going to be something that I think will test us all in our places as to how we ensure that there is a shared accountability and responsibility for using that money in a way and demonstrating the outputs of that money. We have got our collaborative arrangements in place and our place partnerships. I think they're at varying degrees of maturity, but we're looking to try and take the learning from all 4 of those arrangements to actually try and create the best of all 4. And we'll be using that type of structure through a lead provider arrangement to be able to actually test and try and drive some of this forward. As I say, in Coventry and Warwickshire, we have had those lead provider arrangements in place for some time, and the neighbourhood health monies will be aligned to the community integrator contracts that already exist, so that we are being really clear where that money sits. And it's, to Russell's point, not in an acute setting, it is in a community and primary care setting. But I think your question is well made, Suki, and I think it's a case of watch this space, because this is a real test as to whether we can pull this off now.
Thank you, Rachel. Eamon, and then finally Becky, and then I'll bring this to a close. Eamon?
Yeah, thank you. I just want to start by saying well done to the team for putting this plan together in what can't have been easy circumstances. there's been lots of reference so far, quite rightly, to the fact it will be iterative. There are all sorts of reasons why it'll be iterative, but I just wanted to flag in relation to mental health services, for example, and Rachel and other colleagues will be aware of this. There's currently a national review of what's driving demand, also of supply side models, and we're expecting a mental health service framework. One of the things I was looking for in the document, which I found, was in particular in relation to mental health services, that clear distinction between early intervention, prevention and primary mental health care, and also the specialist community services which we need to support that group of patients with severe and enduring mental illness. And I just wanted to flag the Nottingham inquiry commenced on the 23rd of February. There's lots of really important lessons for all of us and for us as a board to reflect on from that inquiry. And it's really important that we keep sight of the distinction between primary mental health prevention, the very specialist services we need in our communities, and going back to the scheme of delegation, some of the forensic services that all link together. And I think that the draft document does that. So congratulations on that. But certainly something as a board we'll want to reflect on over time. And what, of course, the Nottingham inquiry has done is really refocus back on our need to ensure that the public has confidence in the safety of the models of care that we're developing as we move forward. Very pleased to see the commitment to physical health checks in relation to learning disability. And hopefully one of the things we can do on an iterative basis is build on that and make sure that those health needs throughout all of the pathways that we provide across our system really are identifying, flagging and making sure that people with learning disability are given sufficient or appropriate clinical priority, so we can start to really drive the improvement in outcomes that you flag very clearly in the document that we need to be making for that group of people.
Thank you very much, Eamon. Thank you. Becky, finally.
Thank you, Krishni, and lots of things have been said, the beauty of going last, I guess. Just wanted to pick up, it follows on from Eamon and Pete's point around really helpful to see the whole population focus in the PLACE collaboratives. You know, we haven't had that to date, and I think that will really help, you know, obviously taking the point that Eamon has made about those highly specialised kind of more regional services. So it's really positive to see that, particularly across mental health and learning disability and autism. It'd be really helpful, I think, to strengthen in the children and young people's element, the focus on Best Start. You know, going to be really important for us and links as well, obviously, to the patient story that we had earlier. And then a final point about the local outcomes framework. So MHCLG have published the new local outcomes framework, and I think it'd be helpful to link it in with the strategic commissioning plan, because there's quite a few population outcomes in there around children and young people, health and wellbeing and neighbourhood health, that I think will help us around the benefits realisation piece that we were talking about as well. But really positive to see it. Thanks.
Thank you, Becky. Rachel, any final comments in relation to those points?
No, we'll take all of those points on board, Krishna. I just want to say thank you to everyone for their comments. This has been a huge team effort, and I can't think there's anybody in the organisation that hasn't been involved in some way, shape or form in pulling this together, including some of our partner organisations. And certainly for staff in the ICB, they've been doing it at a time of quite a difficult personal situation. So I just wanted to recognise everybody that had been involved in pulling it together.
Thank you, Rachel. Thank you very much. So I think, you know, broadly, I'd probably say that, you know, people endorse the direction of travel. Clearly some questions about how we operationalise, how it fits with the medium-term financial plan, and the kind of estate and people implications that we need to be mindful of. But I think given that this is a sort of direction of travel rather than a final document, which is what Rachel was highlighting, it's really welcome to have your comments so we can look at how we incorporate those and build it into the next step. So thank you very much, everybody, for all your contributions on that. We're now a little bit behind time. That's not uncommon. We will try and catch that up as we go through. But I think it's probably timely, before we go into go back into our spotlight item on maternity and neonatal to take a short break now and then reconvene in 10 minutes. So let's say 10 past 11. And we can then kick off with our spotlight and move on to the rest of the agenda and try and pick up a bit of the time that we've overrun there. So if I can remind everybody that we're on live stream, so you'll need to turn off your camera and your microphone. Thank you. Okay, welcome back everybody. Let's make a start. So we're moving on to item 10, which is our spotlight on maternity and neonatal. We do have a paper supporting that. I wonder if I could just ask Kath and Rachel to provide a little bit of an oversight, but leave plenty of time. I'm conscious that there may be comments and questions, so it'd be great if you can leave time for that and maybe keep the introduction relatively brief to provide an overview of key issues. So over to you both. Thank you.
Okay, thank you, Christian. I'm going to go first and set the scene, and then I'll bring Kath in to talk about the transformation and improvement agenda. So as you'll see from the paper, our local maternity and neonatal systems were created to really improve the quality, safety and personalisation of care for women, babies and families. In both parts of our cluster, through the LMNS boards, we've demonstrated a really strong commitment to delivering high quality, equitable care through close partnership working between trusts, local authorities, and also very much the people who use those services. You'll see from the report that over 17,000 births take place in our cluster each year. And while the birth rate is slightly declining in Hereford and Worcester, we are seeing a rising birth rate in Coventry and Warwickshire, so slightly different pictures. And at the same time, we're seeing an increase in the complexity of care, with particularly high rates of maternal obesity and diabetes, which is reflected nationally, but it is placing quite a different demand on maternity, neonatal and specialist services. We're all aware of the national reviews over the past decade, which have highlighted really important challenges, particularly in relation to safety, workforce pressures, and some cultural issues that have been shown in some organisations. And looking ahead, we are expecting throughout 2026 several more major reports which will help shape future policy and reinforce that constant need for improvement. We have 2 LMNSs, one in each of the ICBs, and they will become one cluster-wide perinatal programme board, which we will look to help oversee the transformation of maternity provision to meet both local, but more importantly, to meet national, but our local expectations and our local patient needs. And I think we're in a good place to do that. Our 2 ICBs have worked together closely for some time, and they have shared learning and supported each other with development and improvements. So our focus will remain on patient experience. It will remain on safety and oversight of outcomes and trying to improve care pathways in the best possible way for the people that use those services. The report describes the work on the outcomes, the transformation and some of the improvements we want to make. And I'll hand over to Kath now, who's actually going to take us through some of that.
Okay, thanks, Rachel, and I'll try and be brief here. I'm really proud to be the Senior Responsible Officer for Maternity and Neonatal Services, and I'm really excited also to become the Executive Lead for Patient and Service User Experience. And I think you'll all agree, hearing Jess's story, I think that is, definitely we're getting things at the heart of commissioning services. Both our LMNSs have continually strived to drive improvements in maternity and neonatal care, reduce inequalities in the delivery of these services, and remain firmly focused on 2 key principles. Our services are designed with the people who deliver them and the families who use them at the forefront of everything we do, with lived experience being embedded into our work across both ICBs, ensuring that decisions genuinely reflect what matters to women, birthing people, babies and families. In terms of outcomes, we've seen some really encouraging progress. Breastfeeding rates at delivery across both ICBs are among some of the best in the country, and they continue to improve. We have seen significant reductions in smoking in pregnancy, which is one of the most significant modifiable risk factors for reducing stillbirth and neonatal death. We acknowledge we have work to do across all areas in relation to securing antenatal booking appointments in a timely fashion, and are working collectively to address this. In Herefordshire and Worcestershire, in-house cessation services at Worcester Acute and Wye Valley Trust are fully established, as well as also in Coventry and Warwickshire. It's widely acknowledged that these preventative measures of improving breastfeeding and smoking cessation during pregnancy really do make a difference to saving babies' lives and longer-term population health. So that best start in life that Becky referred to before. Outcomes are closely monitored through our LMNS dashboards and national data sets. Embrace data provides national surveillance of maternal and perinatal deaths, monitoring outcomes, identifying variation, and looking at safety and quality in services. Overall, our Embrace data has shown improvement in both ICBs, with Coventry and Warwickshire neonatal mortality rates have improved to 1.51 per 1,000 births. Herefordshire and Worcestershire, a slightly higher figure of 1.97 per 1,000 births, but they are on an improving trajectory. Stillbirth rates are showing an overall improving trend across both ICBs. And all of the work undertaken so far sits within the backdrop of, obviously, as Rachel has touched on, the significant focus around national improvement programmes, including implementation of a care bundle called Peri-Prem and the Saving Babies' Lives care bundles. Our providers across both ICBs are achieving near full compliance with the key delivery and safety elements, a really, really good position. Alongside this, we continue to strengthen the use of data and quality intelligence. For example, introduction of the maternity and outcome system Signal, which was implemented in October 2025. As a system, we remain committed to responding to and implementing learning from national reviews, Auckland 1-2, East Kent Reading Signals report, and we're fully prepared for the independent National Maternity and Neonatal Investigation chaired by Baroness Valerie Amos, which will report in spring of this year. Recent national events have also reinforced the importance of vigilance around safety and learning lessons from across maternity care. Looking at the tragic coroner's case in Manchester, where a mother and baby died as a result of concerns relating to the lack of a truly informed decision to have a home birth. This has resulted in a review of our services and local practice, including home birth pathways across all providers. As a result, home births are currently suspended at Wye Valley Trust as a precautionary measure while further assurance work is undertaken. Patient safety remains our overriding priority across both ICBs, and we'll continue to ensure we carefully balance this alongside maximising patient choice within the services that we commission. A key message that we would like the board to take away today is that both ICBs are working collaboratively, investing in improvement, strengthening safety, listening to families, and commissioning services that improve outcomes both now and in the long term. As ever, there is always more to do, but we are moving in the right direction and remain fully committed to ensuring we commission safe, high-quality, evidence-based maternity care for the women of Coventry, Warwickshire, Herefordshire and Worcestershire. Thank you, Chair. Any questions for us both?
Thank you, Rachel and Kath. My apologies, I briefly lost my connection during your presentation, so I didn't hear all of it, but I'm sure colleagues will be able to pick up any question, or well, invite questions and comments, obviously, but if I may come in and ask a question that you may have already answered as part of it, so I just apologise in advance. Okay, so Mary first, and then Vicky, please, and then I'll invite Rachel or Kath back in. Mary.
Thank you both, Rachel and Kath. I guess I just wanted to ask a question around the sort of experiences and outcomes from racialized communities, just thinking about some of what we've seen in the with previous investigations and reviews, which seem to indicate a poorer experience and outcomes. And it was a bit silent on that in this report, and I just wasn't sure how that's being taken into account in terms of the programs of Work with God.
Thank you, Mary. It's a really important point, and I'll just give Rachel and Kath a chance to reflect on that, but bring Vicky in as well. So, Vicky.
Thank you, Chair. And thank you, Rachel. And thank you, Kath. I just wanted to ask a question around the sort of experiences and outcomes from racialized communities, just thinking about some of what we've seen in the with previous investigations and reviews, which seem to indicate a poorer experience and outcomes. And I just wasn't sure how that's being taken into account in terms of the programs of Work with God.
Thank you, Mary. It's a really important point,
Thank you, Krishni. I think my question was really about linking back to Jessica's story before about communication, because all of the multiple investigations, reviews nationally create some anxiety. So it's how we ensure that our communication is really at the top of its game, if for lack of another word, to make sure that we're very clear about all of the improvements we have already made, what improvements we are now making, grouping some of these recommendations so that actually mums are not feeling too anxious with some of the national press around maternity services. So I just wondered if you had a view on how you were going to tackle that.
Thank you, Vicky. So who would like to address that, Rachel or Kath, or both?
I'm happy to start if that's okay.
Yeah.
Thank you for both of those, and you know, it puts in, and I think we're looking at like sort of how we can do things better and how we can work with different communities, and like the communities that are affected by the things that you're talking about. So firstly, sort of kind of Vicky's kind of broader point around that wider like sort of engagement with the population and the communities that we serve. Thinking about this, like what we can see certainly in the CQC patient surveys and things like that, there all the trusts that are served in across our ICBs do really well in that survey, and we're seeing really positive. And then also when Jess and the strategic lead on this side take up those kind of things and actually move them forward and take those comments back into how can the MMVP help in driving forward those improvements. So it's very much in that space. Around Mary's specific comment around that, and I'll take that on board, Mary, and like think how we reflect that more accurately within reports in future. It's absolutely in there. And it's like sort of the leadership of it in there, and like thinking about sort of what are the specific inequalities within each of the areas. And we are really led by the Maternity and Neonatal Voices Partnership leads on that, and looking at various different things. For example, we very recently we did a really fantastic engagement event with Gypsy Roma traveller communities, and looking at that. So it's very much targeted around very specific, and it's very much led by the intelligence on the ground.
Thank you, Kath. I mean, I guess there is some, irrespective of kind of, I obviously don't know the data particularly off the top of my head for Herefordshire and Worcestershire and Coventry and Warwickshire, but we know that women, ethnic minority women, generally have a worst outcome and worse experience in maternity and neonatal services. So I think really recognising that in all of our communication and everything we're doing, I think is really important, because it is sadly a reality that has been the case for many years. So it is just important that we do reflect that. Aman, please, and Vivek. So Aman first.
Yeah, thanks, Krishni. I think we kind of covered it in Mary's question, but I was looking at the engagement with the planning and pregnancy tool and just how amazing we've done in terms of the engagement there. But I guess I was just starting to think about this in terms of all the engagement activities that we do. It's how are we actually measuring that they are translating into improved outcomes and not just engagement? So I guess that, I mean, you could see it kind of came across when it talks about smoking, but I couldn't really see it there. So it kind of touches on what Mary was talking about, but it was just interesting that we've had such huge engagement there, but how are we measuring that's actually translating into outcomes?
Thank you, Aman. And Vivek?
Thanks, Krishni. It's just to say the ambulance sector and us as an organisation, we're actually a maternity provider in our own right as well. So we do around, top of my head, it's just short of 4,000 births a year, it's about 3.5, 3.7. So I guess that would be maybe a medium-sized maternity unit. But we wouldn't necessarily be reflected in this work or what's going on here. So I would just, on behalf of our organisation, would welcome the opportunity to be engaged with and to participate. We do a lot of work in maternity around patient safety, outcomes. We've engaged with the families of Shropshire, for example, who've done a lot of work with us on how we can improve experience and outcomes too. So it's offering an open door from our organisation to participate in anything and everything you do around maternity care and obstetric care more generally. So thank you. Thanks, Christian.
It's a great point, Vivek. Thank you. And that's why it's really good to have you here again. I think because it's an opportunity really to connect more directly, I think, with the work that you're doing. So I'm sure Kath and Rachel would welcome that, because any learning we can gain across all of this is really important. So so thank you for the offer. I'll perhaps take Gail's comment as well, and then bring Rachel and Kath back in if they want to pick up any of those points themselves. Gail?
Okay, thanks, Krishni, and Rachel and Kath for this. It's a wider question, but it was prompted by this report. And I think for me, there's a lot about how we take learning from the past, from inquiries, reports, how we understand. But there were a couple of things in here that I was wondering about. The smoking cessation, I wondered how much the impact of e-cigarettes and vaping had on that. The pressure on obesity for mums. Again, what do we see as the potential implications for the increasing trend towards weight loss drugs? So it was kind of triggered by this, but for me, there was a wider question for us as a system in how do we understand our population, what we know now, but where are we getting the intel to do some of that innovative forward gazing on societal changes, different fads, whatever that's coming through, that means where we think the world is may look very different, and how, if we can get some of that understanding that must be happening, do we use that to really get on the front foot of dealing with some of this stuff? So sorry, it's a big question, but it was kind of really useful for this as an example of there's an opportunity here as well.
Okay, thank you, Gail. Rachel, do you want to comment on that?
Yeah, I think both questions are linked really, and I would say that this is the changes that we need to make as an organisation in becoming a strategic commissioner. We've got to be better at understanding outcomes, and not just by numbers, but actually being able to articulate what that means for the health of the population and the implications for the health of the population. And also, to Gail's question, we've certainly got to get better at understanding some of the trends, both in terms of societal changes, but also medical trends that are going to affect the way that we want to commission services. So I think it's a work in progress. I think some of the work that has been done nationally that we've been involved in, we've been lucky to be involved in with Richard Watson, looks at how we might equip commissioners to start to do some of this. But there's no doubt about it, even the national training programme will not deliver all of it, and we'll have to look for other parties, possibly universities and economists, to be able to support with the way that we've got to think quite differently in commissioning services. I don't know whether Kath wants to add to it in terms of the outcomes work.
Well, I think from an outcomes perspective, we've seen across sites, sort of even thinking about where we started from, thinking about like the services are in a better state of affairs than they were. Certainly, speaking very sort of authentically about Herefordshire and Worcestershire, the services moving into providing good maternity and neonatal care across all units, and then thinking about those outcomes, the population level outcomes, the smoking in pregnancy, the breastfeeding rates driving up. Those are the things that babies lose their lives for. And thinking about that broader question as well, like around what are the trends, and like how is the population changing? It's how we work with public health. It's how we understand that. It's how we take the intel that's out there already as to people around the gallery, around Health Watch and things like that, thinking about what intel have we got about our population and how is our population changing over time, and really focusing on that. I think from an outcomes basis, really, like we have seen in both ICB ICBs, significant increases in those outcomes, those really hard outcomes, those you know, that hardcore outcome that I would talk about from a public health perspective in mortality. So we have seen decreased decreased perinatal mortality. That's the mortality in the early days, and that's really, really positive. And we've seen the implementation of these programs, which then leads to less complications in birth and things like that there. But you're absolutely right. There are big shifts and changes in the population in all of those things, and that is putting different pressures on maternity services. Thinking about that as a commissioner is really, really important.
Thank you. Thank you both for taking us through that. The one thing I wanted to mention was that it is interesting. Simon shared with me a document which I think was the regional director for public health sort of priorities for agreed priorities across public health for the Midlands for 2026, and infant mortality was one of those areas, and it highlighted the importance of, you know, focusing on women's health as part of the broader pathways and various other opportunities. So I think sort of it does recognise all these, as you've rightly highlighted, both of you, that there's a lot of focus on this. So it would be really useful to make sure that's all taken into account. But thank you. This is such an important area. It is heartening to see that we've made progress, and I think, you know, congratulations to all the providers. I think I read that the maternity incentive scheme, I think all our providers are fully compliant against that. So that's a really positive thing. But as you rightly said at the beginning, Kath, this is an ongoing area of focus and improvement. It is something we need to continue to focus on together and drive together. So thank you for taking us through that. And we are grateful for the update and the note that. Okay, we'll need to move on then to the best value care in the right setting point prevalence audit update, and it's over to David Mahaffey for that. David, in the interest of time, I'd be grateful if you could focus on any key points you want to highlight and the agreement you want for the way forward. Thank you.
Yeah, sure. Thank you, Christian. I was going to say we're 15 minutes behind, so I will whiz through and not spend too much time talking through the detail of it. Just want to flag, obviously, from the outset that this is only a report that applies to Herefordshire and Worcestershire. It's a legacy piece that's hung over from before the cluster arrangements came about, because the work started before then. Obviously, a lot of focus today on left shift. This report is all about really measuring where the left shift is happening. So just a quick reminder of what point prevalence audit is. It's an annual audit that takes place on the 3rd September, the third Wednesday of every September between 10 AM and noon, looking at every patient who is in what I describe as not normal for them care setting. So in an acute bed, a community bed, on a discharge pathway, in a hospital at home, a virtual ward, something like that. And the question is asked, is the patient in the right care setting for that point in time? We've done it for 4 years now. This is the 4th year of 5. This year we audited the most patients we've ever audited at 1,799 patients, which is quite a jump up from 1,614 in 2022, and it's 103 patients more than we audited last year. That is on a like-for-like basis, so you're quoting kind of sales growth on the high street. It's like-for-like, so that 100 extra patients this year represents additional services that we're having to put in place to cope with increasing demands on our services. The headlines are, jump straight to the headlines, that this year we saw more patients treated in the right care setting than any other year that we've done to date. Particular increases were noted in Herefordshire community hospital beds, which are now up to 65% in the right care setting. Worcestershire acute hospital beds up to nearly 80% in the right care setting, alongside those in Herefordshire, but a small decrease in Worcestershire out of hospital care settings. I'm going to jump straight to the so what point on this particular piece of work, because that's what counts on this. This is about measuring progress on investments and our strategy to get the right patients in the right care settings to make the best use of our resources. So we are now at, across all patients, 75% in the right care setting in the 2025 audit, compared to the starting point of 68% in the 2022 audit. I mean, that's a really significant improvement over that time period, but it's still quite a long way to go. We'll never get to 100%, but the opportunity that still exists for us is measured in the tens of millions of pounds if we can increase that number to 80, 85%, etc. So I feel it's moving in the right direction. Our work is demonstrating impact, but there's still more to go. In terms of what next then for this particular piece of work, the original commitment in 2022 was to run this as a 5-year project. This is clearly year 4. Clustering has come along, so it leaves us with a decision point at this point in time as to whether we carry on as we are or do something different. The report contains 4 options. Option 1, continue in Herefordshire and Worcestershire as normal for year 5 and end the project next year as planned. Expand the audit into Coventry and Warwickshire for next year. Option 3 is a mix of the two, which is to complete Herefordshire and Worcestershire's 5-year project and then maybe reconvene a new cluster-wide project from next year. Or option 4 was to cease the project 1 year early, recognising how things have changed with the cluster. Apologies for any confusion in the report. There was a typo at the end of the report. Just to be clear, the recommendation I'd like to put forward to the board is option 3, which is to complete the Herefordshire and Worcestershire year 5 audit this year and then maybe take a view next year on whether we move to a cluster-wide audit and run that for a further long-term 3 to 5 year period. So I'll pause there, Krishni, in the interest of time, and open for discussion or questions.
Thank you, David.
Yes, thanks, Krishni, and thanks, David, for a really interesting bit of work. When we first came across this, I think I was questioned 3 years ago how useful it was going to be, but actually, as I see, it's become increasingly relevant and increasingly helpful as the time has gone on, showing us the trends, showing us the trajectory, and I think it's a really great bit of work. So I would absolutely endorse option 3 as you've suggested, because I think it's exceptionally helpful and would love to see that wider across the clustered organisation. Some other points just to make on it. I think it's really important when we start looking at the possible changes and possible improvements we could make, that we think about a kind of Pareto basis for this and actually don't try to address everything at once, but actually address the biggest option and make sure that we get the biggest impact in the kind of biggest area rather than trying to address everything at once. I think that's the way for us really to get impact. Second would be a question, am I reading it correctly in thinking that we could make a really big difference by having a few more community beds in Worcestershire, or is that a misreading of that? And the fourth is just a kind of personal reflection that you mentioned the urgent care response teams. I had personal experience of that within the last few weeks with my mother-in-law in a different system. But I was really struck by how helpful those teams are in actually getting care at the right place and avoiding people being brought into hospital who definitely shouldn't be there. So I wanted to make a quick plug for that urgent care response teams, which I think have done a fantastic job.
Thank you, David. Shall I just take Vicky's comment as well, David? David, I'm happy and bring you back in then. But Vicky.
Yeah, and mine is very similar to David's points, but it was really, I guess, I would support the recommendation that you've made, David, but in terms of actually the benefits realisation of all of the schemes in terms of left shift and all of the support for the urgent care system, are we able to more closely monitor, be cited on exactly how much we want to ramp up in each of the schemes? So if I use, for example, the virtual bed utilisation, there's some data within the report that outlines that. So it would actually, what would our KPIs be in that area in order to get improved utilisation again at the end of this 5th year? So it's very similar to David's, but it's just actually how we as a system could be cited on, these are the improvement areas that we're going to make in order to see X percentage more by the end of the 5th year, if that makes sense, David. Apologies.
Okay, yeah. Thank
Do you want to comment? Yeah.
Shall I come back on this? I mean, firstly, thank you for those comments and questions. I mean, to take the biggest impact area, David, I think was the first point you made. Clearly, it's getting better use of community hospital beds, but I don't think the conclusion of we need more community hospital beds is the answer. I think it's better out or more capacity in out of hospital settings to enable those patients to be able to move more quickly out of community hospital beds back to their own homes or back to a care home if that's going to be their new place of care. So I think more investment in the left shift to create better use of the community hospital beds rather than more community hospital beds. And to Vicky's point about having the right sort of KPIs in place, yeah, I agree entirely on that. We need to maximise utilisation of these resources, and anything that's kind of less than 95% is probably not maximising utilisation of the resources. So our KPIs need to be very much geared in that area.
Thank you, David. I'll bring Eamon in and then we'll go to your recommendation. Eamon?
Yeah, I mean, David to an extent has covered the point I was going to make, but it is striking that the lowest percentage of patients in the right care setting is in community hospital. I think therefore it will be particularly interesting to see, and I certainly support option 3, what the numbers look like for Coventry, which doesn't have that service provision. So my only question for David was, are there other systems around the country who've been using PPA, and if there are, how do our numbers compare with them?
Yeah, I mean, I did a bit of research on this a few years ago before we set it up, and we found particular targeted projects, but not system-wide projects. But I know Rachel said that there had been some system-wide work done in, I think it was, I'm not sure the whole of the Cobham Warwick system, but certainly in parts of the Cobham Warwick system that we could probably draw upon. But I haven't come across anything like this anywhere else in the last couple of years.
Thank you, Eamon. So, so David's ask is that we support option 3. I think it allows us to take stock of to manage this year, which was, I think, always intended to be something we took forward for Herefordshire and Worcestershire, but not necessarily try and expand it. I think, as I understand it, David, whilst we're in the process of still managing internal change, but with a view to taking stock and hopefully moving it forward to Coventry and Warwickshire in the future. Am I right in interpreting in that way, David? That's the recommendation.
Yes, thank you.
Great. So can I ask that, and clearly just to highlight throughout all of this, I think all partners have been involved in interpreting the data and making sure we all understand the data in the same way. So it's really important part of the process that's been a key part of it really along the way. So can I ask for the support for option 3? I think most people have indicated that in some guise or form, but that's great. Thank you very much, David, and we look forward to see the work continuing in the form that we've described, which I think has been really helpful to, as you say, to demonstrate the focus on left shift and movement of our resources. Okay, so we move on to the item 12, which is the system quality and delivery report. So Mary and Kath, over to you for any key highlights, please.
Okay, thank you, and morning to everyone. I'd just like to start. We're going to do this report in 3 ways. Have a very brief conversation about the transition to the cluster arrangements for the oversight of performance and quality. We'll just highlight the key performance issues, then hand over to Kath for the key quality issues. We've discussed much in this board meeting about the move to ICB being a strategic commissioner and the different way we need to work to meet the needs of our population. So please take this as a transition report for our cluster, the 2 ICBs. From April, we will be bringing together an integrated subcommittee of the board for quality and performance. We've maintained some of our current infrastructure, but that will change going forward. And the reports in future will be based more around remaining oversight of the NHS constitutional standards, because we do need to understand for our population how we're performing against that, but more about the NHS oversight framework and how our system is delivering that, and our commissioning and population outcomes. When we set the commissioning outcomes in the strategic commissioning world of the future, we will be reporting through to this board how we're delivering against those. The regional role is changing in performance management, and we're still in that transition period, and we're still working with the region to make sure that the transition is as seamless as possible. And also, obviously, from next year, financial year, the ICB itself will be assessed against the NHS oversight framework, and will be allocated a segment based on performance against a basket of measures. We're still waiting to see those baskets of measures, but the first quarter performance will be published in August, so you'll be seeing in future reports how as an ICB we are performing. So this will be the last report in this format. It will change going forward. Just a very brief overview then of the key issues. So urgent and emergency care. So obviously focus in the recent month has been on delivery of the cluster-wide winter plans and mitigating the risks that are presented by winter infections and the periods of escalation. Really looking back, January was our most escalated month over winter. I think it's fair to say it's probably been apart from that, one of the more stable winters that we've had in recent years. Touching every piece of wood on that one, but it has been stable in that position. And we will, although we have got still hospitals with very high occupancy, ambulance delays, challenges in performance, etc. From an escalation point of view, it has been more stable. What we're intending to do across the cluster, a bit like we did earlier in winter, we'll be providing the board with a separate email on the evaluation of winter across the cluster, and we can use that going forward to determine, do we need to commission in a different way for next winter going forward. Just of note, for urgent care, the NHS system has put in a sprint for emergency care for March. It's a sprint to improving the 4-hour performance standard. We are seeing some improvements across the four places in our cluster. We will know at the end of the month if we do hit those targets that were set and understand what the improvements need to be maintained and sustained going forward. So we'll report that at future meetings. Regarding elective care, just to I think we all know the key end of March target was around eliminating 65-week waits. We have at the end of February 12 patients in Hereford and Worcester and 0 in Coventry and Warwickshire waiting longer than 65-week waits, and we are anticipating we will be at 0 at the end of this month. We're watching it day by day closely to make sure we achieve that and taking any mitigating actions. The next challenge for us is the 52-week waits in elective care, which is a whole work stream going on across all the places to achieve that in the relevant timescales. We maintain for cancer our tiering support, and obviously 62-day treatment standard is the one that's challenged in various areas across our system, but there are very detailed improvement plans that we'll continue to oversee and see if we achieve those outcomes and commission in a different way if we need to. The only other thing I wanted to highlight from a performance point of view was about children and young people with a learning disability in Coventry and Warwickshire. Due to a historic underreporting issue that was corrected in November, we're now seeing a higher reporting of those children in a mental health inpatient setting per million population. I don't believe this is just a Coventry and Warwickshire issue. The region are looking at the whole region at the moment, so I think there will be a change in reporting. I think we've just discovered it first in Coventry and Warwickshire. We're rapidly looking at Hereford and Worcestershire at the moment. It doesn't mean there's more children, it means that we haven't reported it correctly, and we're doing a deep dive on that at the moment. So that's an overview of performance, and then once Kath's finished, happy to take any questions on performance, and Kath will pick up the quality issues.
Great, thanks, Mary. I take the report as read. However, I want to highlight the positive progress made in relation to Clostridioides difficile across Herefordshire and Worcestershire ICB. I think, as some of you will know, we've been on a significant journey of improvement with this in the past few years, and I'm delighted to report there's been sustained reduction in the number of cases, across Herefordshire and Worcestershire since January 2025. This has now been de-escalated on our risk register and gone up from the board assurance framework to assurance, which Hannah will detail later. And just wanted to kind of note, just if you took the cut of the data today, Worcester Acute is now #1 in performance for Clostridioides infection out of 138 acute trusts, with Y Valley Trust being number 50. So a really big change from being at the very bottom to now sort of punching well in the middle and up to the top. So just wanted to highlight that for the board. It's been a significant journey, and happy to answer questions on any of the other things as well. Thanks.
Thank you, Kath. Any questions on any aspects of that report? I mean, I was going to bring it up later, but yes, I think really important to recognise that journey about the improvements in infection prevention and control, particularly the CDI. So I was going to bring that up later, but as Kath has mentioned that, it's really good to note that. Any other comments or questions? I think we look forward to receiving a review of the winter plan and what that might mean, as you rightly said, Mary, going forward. Important to say, I think that NHSE felt our winter plans were the most robust they've been, and to some degree you could probably conclude from where we are at the moment that that has helped, but not necessarily completely eased all the issues, but I'm sure there'll be some positive learning from that and opportunities to take that forward. So thank you, Mary and Kath. We note that and move forward to financial plan and delivery, which is item 13. Over to you, Mark.
Thank you, Chair. So again, conscious of time, I'll just pull out some of the key points in terms of where we're at. And just give a quick overview. We've now got the month 11 data as well, just to make sure the board's got the latest positions. So that the paper covers both of the ICSs and takes us up to month 10. So it reports up to the January position. And we have included a bit of an update around medium-term planning. And just to note on that, we are doing an alignment exercise with NHS England, which has to be submitted today. So this is just the final bits really around contractual alignment, which I know Simon talked about earlier. From an ICB perspective, both of the plans are still compliant, still meet the balanced financial position, but we are looking at how we stretch efficiency to at least 2% in both ICBs there, to really look at what are some of the opportunities then around priming some of the change and going further on the strategic commissioning plan, as Rachel touched on earlier. The paper is also asking for an approval as well today, as we get very close to the end of the financial year, and we'll soon be doing the 25-26 annual accounts for both ICBs. Again, just seeking approval to delegate the sign-off of those accounts to the Audit Committee in common. So I'll just give you some of the key headlines then in terms of where we're at and the month 11 position. So we've now got month 11, which takes us to the end of February. And what we've seen there is across the cluster, there's been an improvement of about 1.4 million in terms of the overall position. So across the cluster, we are still reporting we're behind plan by £13.2 million. When you break that down then between the two ICS areas, the Hereford and Worcester element is at £11.2 million behind plan, and the Coventry and Warwickshire ICS is £2 million behind plan. So I'll just quickly touch on the Herefordshire and Worcestershire side. So between month 10 and 11, we have seen an improvement. So month 10, you'll see we were 12.6 behind plan. It is down to 11.2 million behind plan. If there is a small improvement within the Worcestershire Acute Hospitals NHS Trust, which has moved from being £18 million off plan to 16.3 million. As I've touched on previously, the Trust do have a very detailed financial recovery plan. Off the back of that recovery plan being reviewed and assessed by NHS England, acknowledging there was still financial risk, the Q4 deficit support payment, which I think I briefed on last time that had been withheld, has now been released. So that £18.3 million was released. but it is going to be very tight as we get to year end, and there is a very real risk we might be a little bit short of where we need to be, but the trust are pulling out all the stops to make sure they can get to the position where they need to be at year end.